This lecture is going to be on Chapter 4, Hemoglobin Function and Principles of Hemolysis. At the end of this lecture, the student will be able to identify the components of hemoglobin, define the structural elements related to hemoglobin to include globin chain synthesis, describe hemoglobin function, describe the origin of hemoglobin synthesis and erythroid precursors, list the normal adult hemoglobins, describe the chemical configuration and percentages of the normal adult hemoglobins, hemoglobin A, hemoglobin A2, and hemoglobin F. List the conditions that may right shift or left shift the oxygen dissociation curve. Describe hemolysis in terms of its effect on the bone marrow, blood smear, and blood plasma. Define extravascular hemolysis with respect to organ or origin and laboratory diagnosis. And lastly, define intravascular hemolysis with respect to organs affected and laboratory diagnosis. When it comes to red cell composition, we have our heme, and the components of hemoglobin are iron, the porphyrin ring, and globin. So with heme, you have 4 iron atoms, or iron 2+. The iron is surrounded by the protoporphyrin ring. You have globin, which are 2 pairs of globin chains that are made up of amino acids. These are both alpha and beta chains, 2 pairs of each. And you also have D3-DPG, or diphosphoglycerate. That's produced via the Embden-Meyerhof pathway, which we discussed on Chapter 3's lecture, and that's related to the oxygen affinity of the hemoglobin. Here you can see a hemoglobin molecule. You can see there are 2 beta chains and 2 alpha chains. The arrow is pointing to the heme in the middle of those globin chains. When it comes to hemoglobin synthesis, the function of the red blood cells is to produce, package, protect, and transport hemoglobin among our various tissues within the body. So hemoglobin has different jobs that it has to carry out. It's responsible for carrying the oxygen, or the oxyhemoglobin. It pulls CO2 away from our tissues. It carries those away that can be exhaled by our lungs, and it works to keep a balanced pH within our blood as well. There are 3 types of hemoglobin in red blood cell production. We have embryonic hemoglobin, fetal hemoglobin, and adult hemoglobin. Those can be tied to different genetic components, such as tied to chromosome 11, where you have different genes upon that chromosome 11, as well as chromosome 16. The embryonic hemoglobin, we have hemoglobin Gower 1, hemoglobin Gower 2, and hemoglobin Portland. Fetal hemoglobin refers to 3 months of development as a fetus, as the name indicates, and that would be tied to hemoglobin F. When it comes to adult hemoglobin, that's going to occur 3 to 6 months after delivery, or after a baby is born, after we're all born. You have hemoglobin A, which makes up 95 to 98% of the hemoglobin. Hemoglobin A2, which consists of 3 to 5%, and hemoglobin F, which is less than 2%. The oxygen dissociation curve gives us reference for the binding and release of oxygen from the hemoglobin molecule. We also have what is known as the OD curve, which is a sigmoid or S-shaped curve. The increased bound oxygen is when there's an increase in PO2. So the lungs, in reference to the lungs, the PO2 is 100 millimeters of mercury, or at 97%, and this shows the hemoglobin saturation with the oxygen. What's in actual circulation is PO2 is 40 millimeters of mercury, or 75% hemoglobin saturation with the oxygen. So this gives you a visual of the oxygen dissociation curve. At the bottom, you can see the bottom axis is the tissue PO2. And along the vertical, we have the percentage of hemoglobin oxygen. So the blue is what you would see as a normal oxygen dissociation curve. And when it talks about a shift, it means a shift to the left or shift to the right. So a green is a shift to the left. You can see it is literally shifted to the left, and that's hence the name. So it is moved more in this direction, and a shift to the right is the opposite of that, and you can see it is shifted more to the right here. So what does the OD curve tell us? Well, the changes or the shifts, if there is a shift to the right, it shows us there is less attraction to the oxygen. At 40 millimeters of mercury, the hemoglobin is at 50% more saturated, but it's willing to give up 50% of oxygen to the tissue if it's needed. It has a lower affinity, which means there may be issues such as anemia, acidosis, which means there's a decrease in the pH, an increased D3-DPG, or sometimes it can be related to an elevated temperature, otherwise known as a fever. When there is a shift to the left, that means there's more attraction for oxygen. At 40 millimeters of mercury, the hemoglobin is at 75% more saturated, but it's willing to release only 12% to the tissue. So you can see where that is much less than when there's a shift to the right. There's a higher affinity, there's a presence of abnormal hemoglobins, there's alkalosis, which is an increased pH, not a decrease, which is the acidosis, a decrease in the D3-DPG, or possibly a decrease in the body temperature. There could be multiple transfusions of stored blood where the D3-DPG is actually depleted. In reference to abnormal hemoglobins, the one abnormal hemoglobin is the methemoglobin. The iron is in an iron 3+ state, so it's not capable of binding oxygen. It needs to be in the 2+ state. If it's greater than 10%, the individuals may appear cyanotic, which means the tissues have become blue in nature. I have a blue color or blue hue. It can be induced by aniline drugs or hemoglobin M. We also have carboxyhemoglobin, which has a high affinity for carbon monoxide. It can lead to carbon monoxide poisoning, and it's increased in smokers and certain industrial workers who are probably exposed to some type of smoke or carbon monoxide. Lastly, we have the sulfhemoglobins, which has an affinity for oxygen. When it's lower, it's formed through exposure to sulfonamides or sulfa or sulfur. Sulfa is the prefix for that, containing drugs. Hemolysis is a term that means the premature destruction of red blood cells, so meaning they have not lived out their 120-day average lifespan, and they are starting to destruct based on various issues or disease states before their due time. When it comes to hemolysis, you have extravascular and intravascular. Extravascular is 90%. That involves the reticuloendothelial system, which is comprised of the tied to the spleen, liver, lymph nodes, and bone marrow. It releases the heme and the globin contents. Therefore, they can be recycled and used again for more red blood cell production. We also have intravascular, which means the red blood cells are lysed directly into the actual blood vessels. With extravascular hemolysis, you will see a decrease in hemoglobin, as well as a decrease in the hematocrit and the red blood cell count. You would see an increase in the reticulocyte count, where the body is trying to rebound with producing more red blood cells. With the retic count being elevated, you will see polychromasia in the peripheral smear, an increase in the serum bilirubin, which we know is tied to the liver, a decrease in the haptoglobin, an increase in the LDH, which is the lactate dehydrogenase test. That is going to be increased due to, it checks for tissue damage. So if it's increased, that means there is tissue damage or something going on with, in that regard. And you also have may have the appearance of spherocytes on the peripheral smear. When it comes to intravascular hemolysis, you would also see a decreased hemoglobin, hematocrit, and red blood cell count, an increase in serum bilirubin, a decrease in serum haptoglobin. Hemoglobinemia, meaning there's free hemoglobin and the plasma may appear red or pink tinged in the sample that is drawn from the patient. Hemoglobinuria, possibly an increase in the reticulocytes, an increase in the LDH, as we just discussed, and the smear may show schistocytes. There are types of anemia known as hemolytic anemias, where there's the breakdown or destruction of red blood cells. There are different types shown in this chart. So it says that the hemolytic anemia is classified by intrinsic or extrinsic defects. So intrinsic red blood cell defects leading to hemolysis. You have hemoglobinopathies, which are structural, can be structural and synthetic. Red blood cell membrane defects, red blood cell enzyme defects, or stem cell defects. When it comes to extrinsic defects that lead to hemolysis, you might have autoimmune hemolytic anemia, a parasitic infection, microangiopathic hemolytic anemia. It could be due to environmental effects, including venoms or even chemical agents.